David, 5 seconds. And we're broadcasting.
Hello, and thank you for joining us for today's ILC webinar, where we are working with the International Vaccines Access Centre and Johns Hopkins University to explore the lessons from COVID-19 for health ecosystems across the world. Before we get started, a few housekeeping issues. Internet issues may impact upon our sound and video, so please bear with us. As some of you will know, and from my background, you will see that I am in sunny Bognor Regis, but our infrastructure isn't brilliant. So my internet may not be as good as it should be, but let's hope we survive through it. At the bottom of your screen, there is a chat function to communicate with panelists and delegates, as well as a Q&A feature. Please put your questions in the Q&A box at the bottom of your screen so that we can have the conversation with panelists. Please also post your comments on Twitter using the event hashtag Canary in the coal mine. The webinar is being recorded and is being currently broadcast on our website, and will be put on our website. It's on YouTube, so you can also watch there and indeed add some comments as you are watching. A few things to kick off. Firstly, I think I wanted to say that I suppose 3 things that I'm really, really proud of. One is extraordinarily proud of our ability and the way in which we have managed to engage with businesses, with policymakers and with academics. And today's webinar is no exception to this. So, for example, it is brilliant that we are here with Home Instead, really leading business in the space of home care. Really, really pleased that we have policy leader, global policy leader, Mike Hodin with us today from the Global Coalition on Aging, and of course, Johns Hopkins University from academia. So it's brilliant that we can bring together those sort of expertise from those different areas. Secondly, really, really pleased that actually we are managing through the miracle of the technology to bring people from across the whole world. So today we're broadcasting to you from New York, from Nebraska, from Bognor Regis, from Baltimore, and from Portsmouth. So we're coming across the whole world, and next week the Global Alliance will be spread even further. We'll be coming from across the whole world with the ILC Global Alliance. And then the third thing I wanted to say is actually really, really pleased that we have got, we're joined by so many friends here on the webinar in terms of the audience, but also in terms of our speakers. So as I said, Mike and the Global Coalition on Aging have been extraordinarily important partners to ILC UK and the ILC Global Alliance for a long time, dating back to before the Global Coalition on Aging, where we worked very closely together. Similarly, Johns Hopkins University, and I just want to say a quick thank you to Lewis Prevost-Dunn for all of the work we've done together with Johns Hopkins University over the last few years. And they have been extraordinarily influential, particularly at the moment, of course, with the modelling and other work they're doing on COVID. And then Home Instead, we've also had a very long relationship with, and my boss, as you may know, Baroness Greengross, has worked very closely with Home Instead for a long time. So that was all I was going to do by way of introduction, except to say, the aim of today's session is for us to focus on lessons from the experiences of old adults in relation to COVID-19 for health ecosystems. So without any more ado, other to say, please do use the hashtag Canary in the coal mine on Twitter. I'm going to pass over to Antonio Tubero, and I knew I would fail with the pronunciation. I'm so sorry, Antonio. Antonio, please, is joining us, Professor of the Department for International Health at Johns Hopkins University. Let me pass over straight to you now.
Thank you, David, for a nice introduction. And thank you for inviting me today. It is my pleasure to attend this conference in such an important topic of aging and COVID-19. I think it has been a neglected issue, so efforts like these are great. So before I start laying out the argument that I have for today, I just wanted to see how, I wanted to tell you how economists tend to look at pandemics. Pandemic, it's an externality, and you see the economists solve externality using prices like subsidies. So if you smoke, you subsidize, you tax the activity. In the case of the externality of pandemic, it's very difficult to use the centralized price systems or to use the legal system. We don't know where the infection happened, you cannot serve. So we are in a system where we need central plan policy. We need policies, and when you need these central plan policies, you need three fundamental elements: cooperation, trust and leadership, and managing an expectation. So my first argument is to pay attention to the seniors and the elderly. You have to design policy that look at cooperation across the generation, trust, and expectation. The second argument that I wanted to say here is that COVID-19 have hit very harsh the elderly. So just to give you an example, I've been working closely with the government of Colombia. Colombia has been doing much better than most of the country in the region. Today have 40,000 cases. Yesterday was around 1,200, 1,300 deaths, much less than Peru, Brazil, and Mexico. But when you look at the data by age group, we're gonna see something interesting. We're gonna see that the average death rate is deaths compared to cases is 3%, but when you see by ages, it's much higher. The group between 70 and 80 have a death rate of about 15%. When you see about the total cases of death, 70% is in this group. So you see a gradient in age, and you see a higher number of 35% of the cases, but higher number of deaths in this group. So COVID-19 had hit very hard the senior citizens. So when you think, moving to the third issue, when you think about the type of policy that we have used, so we can divide in the two phases. In the first phase, most of the countries, and the country that I work very closely, Colombia was trying to reduce the spread of the disease, such as you don't have an overwhelm in the health system. So basically all the work was to reduce this speed. And most of the non-pharmaceutical interventions were used, and the other concern was, try to have input to the supply side. You move to the second phase, and it's open the economy, and a very fundamental policy that I wanted to discuss, because I don't have time to discuss all the policies, the lockdown. And some countries have used what is called selective lockdown, meaning I'm gonna keep the household who have elderly in their home to protect them. To me, the idea of household selective lockdown could be contradictory. Why? Because if you have selective lockdown and you let the younger people in the household, a lot of households in Latin America have an elderly and extended family, go out, when they come back, when he or she come back, the risk will be higher. So I'm not so sure that you are protecting them more. Then if you make the decision to keep the whole extended family in the house, you can create problems of traded off between violence against the elderly because the younger cannot work, a lot of issues, a lot of negative issues. Then the lockdown created a heavy burden on the elderly, on the senior citizens. So these two issues need to be weighted. So in the second phase, what I propose is that rather than thinking about geographic areas, controlling the epidemiology, you also have to think more carefully about target the vulnerable of the virus. And the seniors, of course, are a very important group. So moving from geographic to target policy, geographic, it was very good in the phase one. Target may be much better in the second time. You need to have trust in the testing. You need to have target in the vulnerable group. You need to have community empowerment, and maybe you need to use tracing that is not just based on technology. We need to think about outside the box to trace and insulate the senior citizen. Moving to the third issue that I want to touch today, I wanted to touch a little bit about policies, and policies that I'm very interested to move forward in the region. First and foremost, I would like to have money in the public stimulus in each of these countries target to the senior citizen. Issue number one, we have paid a lot of attention, and rightly so, to stabilize the economy, to protect the unemployed. We have to put money to help the elderly and to help the people who take care of them. Issue number one. Issue number two, I as an economist, I'm a weird economist that some people will say, I do truly believe that we need to rely more on on marketing. We need to do much better on marketing of social policy and public health to protect the senior citizen. I think the main message here will be that there is a contribution across generation in both ways. The younger protect the senior, and the senior may stay at home to help the younger. So it's not just the message of protecting, it's the message of two-way direction. But I think that we need to do much better in marketing. The second issue I would say is on informal care. Informal care is a very important source of care in Latin American countries, in the US. Also, some people estimate that the industry has a value of more than $300 billion. So how can we protect informal care? We can provide subsidies. We can, it's a very difficult activity to incentivize with economics, but you can encourage firms to provide flexible contract, protect the people who provide care, but pay more attention to informal care. The next issue that I will say that it's important, and let me check time, it's the idea of changing behavior. And the idea of changing behavior for senior citizens is very difficult. Motivation and friction make very difficult to change behavior. So two things are very well known from behavioral economics. One is the change and the pain is much less if I know a time frame. Second, the change and the pain is much better the change is better and the pain is much less if I in control of the situation. So time frame and control are two things that we need to pay more attention when we design policies to help the elderly. Moving again to the next issue that I have for you today is the idea of the long-term care and nursing home. And I'm going to be brief here, but initially what we saw was the supply of informal care in a lot of society will go down because more women will be working, we have less fertility, we're gonna have more adults. So we're gonna need institutionalized care in different ways. So what we have in this pandemic is that the institutionalized care have made significant lack of quality, a lot of death, around 40% in certain places, in Massachusetts, for instance, and a lot of countries are happening in long-term care. So to me, the issue is not only regulation, but capacity to regulate. So all of the issues that are around incentive, how much you pay the people who work in nursing home are important. The issue of testing, the issue of pool testing have not been touched a lot in these settings. I think it's important. I also wanted to bring attention to an issue that I'm seeing too many people are talking about, which is a consequence of COVID-19, which is the idea that a lot of care has been postponed because people have fear to go to the hospital. So we're going to have a backlog in care. So we know that there is a lot of discretionary care. For some economies, it could be a good news because people may have long time to search for better care. But I think that the thing that we need to pay attention is how this postponed care will affect the elderly health. In my opinion, that's a very important issue to keep tracking in the future. The last couple of issues I want to touch for today is the idea that we need preventive care, we need vaccination. Beside the vaccine that we hope we're gonna put in the market to protect for COVID-19, elderly citizens have to have the pneumococcal vaccines that are the preventive care. That's really important. Now, regarding the new vaccine, it's a big topic in the United States is to accelerate the production, having factories ready to produce. Many factories, some of them can fail, using incentive, what is called push and pull, to provide these factories to produce once the vaccine is discovered. To me, my concern is that nobody's talking too much about what happened with this vaccine, how this vaccine can be adapted for for the elderly population, and who's going to be using first. It seems to me that 70% of the deaths are concentrated, and this is worldwide, in the elderly. I think that we should pay more attention to that. So in conclusion, I think that it's very important that we, now in this second phase, target policy to help the health of the senior citizen in each country. We have the tools. We have good news. We have innovation. Or other of the panelists will be talking about telemedicine and how we have been taking this crisis to innovate. But we also have to take this crisis to improve our attention and our care to the elderly. Thank you, and over.
Great, thank you so much, Antonio. That's really, really good. I won't attempt to summarize it, but I think that clearly, you know, I think your point around the sort of the backlog in care and its impact on older people's health is extraordinarily important, but as indeed is the backlog in access to health and what the long-term impact of that might be. We're gonna go to questions at the end, and just to have our few contributions at the beginning first. So we're going to go from Baltimore via Columbia, of course, to Portsmouth, where my colleague Lily Parsi is going to talk a bit about the work that ILC UK have been doing on public policy in relation to prevention. Just to remind you again, please do use the hashtag Canary in the coal mine, or in the coal mine, and on Twitter, and we will grab some comments from there. Lily.
Great, thank you. And Antonio, some really, really interesting points. I think especially the sort of health education point is really, really important at the moment. And I think hopefully we can actually learn a little bit from COVID-19. I think in the UK at the moment, we've not been doing a very good job at it, but hopefully some other places are doing better. So yeah, as David mentioned, I'm going to be speaking a little bit about a program of work we've been doing on preventative health interventions in an aging world. And sort of looking, I think sort of COVID-19 has really put a light on just how important it is. It's also a really good opportunity to kind of see how we've been doing so far. So I'll be running through that a little bit and really what needs to happen next. So both in the short term, as we're sort of coming out of this pandemic, but also more long term. So this is a very quick bullet point list of the key things I'll be running through today. I think COVID-19 has shown us sort of on the first level and really universally quite across the world is we're not really prepared. And I think especially in the UK, and I might also speak on the behalf of my colleagues here in the US as well, you know, we've really fallen behind at the moment. In the UK, there's a lot of debate about a report that's come out on claiming that if we'd started lockdown measures a week early, we might have been able to halve COVID deaths. Obviously, that's not entirely clear, but I think there's clearly a point that, especially in the UK, we were very late to react and to have a real plan of action. It's also shown us quite how many people are not only at risk, but also at really high risk. I think in the UK, we've sent letters out to 2.5 million people, so it's about 4% of our total population that are at such high risk that, you know, they're having to shield. And lots of this is really preventable. And I think it's showing that really for decades we haven't been doing enough to make sure that preventable conditions like diabetes, like cardiovascular disease, like COPD aren't developing. I think it's shown us that some of the debate around prevention and also in context of this pandemic is a bit ageist, and that we need to rethink some of that. Again, here in the UK, we've you know, there have been debates around, well, should we just do a blanket shielding rule for everyone over a particular age? And I think it's shown also that, you know, we haven't been doing enough so far to make sure that preventative interventions aren't only available when you're young, but actually people are not sort of looping in and out of the health system, but are staying in and really having these interventions when they need them all across their life courses. I think it's shown us quite how high the cost of failing to act is, and you know, both to our economies, to our health systems, and really, you know, right across the board. I think at this point, no sort of government department, no organisation or company can really say that this doesn't affect them. And so if we're looking forward and towards prevention, then, you know, it's everyone's business really. And finally, I think we need to learn from this, and hopefully there'll be some, out of this whole crisis, there will be some really useful learnings that we can use going forward. So over the last year, we've been doing this work on prevention. You know, these figures won't be surprising to some of you. Clearly, the burden of preventable diseases is really big, and we're seeing, you know, as populations across the world are continuing to age, that burden is growing. So actually, in the next 25 years, we're expecting it to increase by 17% if we don't sort of move upstream and prevent these conditions from appearing in the first place. I think COVID-19 has shown in lots of cases just quite how overstretched our health systems are already. So, you know, realistically, how are we going to deal with another 17% of people with underlying conditions that will have complications when something like this occurs? But also more routinely, outside of a pandemic, we'll need treatments. And yet, despite this, and despite there being a very clear case, you know, we're still seeing a little bit of ageism in how we think about prevention. So, you know, why is it, for example, that the WHO guideline for immunisation uptake is 15% lower for adult immunisation than it is for childhood immunisations? And that goes right across the board, really. And it shows. So, say here, this is a quick graph just of the uptake rates for flu immunisation across the WHO European countries. And we see the UK here does sort of fairly well, but even so, we're still falling short of the WHO's target of 75%. But then on the other side of the board, countries like Latvia and Slovenia, you know, have close to no uptake rate at all. So there's clearly a long way we need to be going. This quick slide just to show, you know, I think COVID has shown again, you know, in really big capital letters, just how important it is that that prevention isn't just, you know, for when you're younger, and that from that point onwards you only come in to be treated for conditions. And as part of our work, we were also looking at the economic impact. Obviously, at the moment, it's become clearer than ever. But even so, we, you know, across just a small number of preventable and age-related diseases, we're seeing huge losses to productivity. So these numbers here are just lost days of work due to sickness or what's called presenteeism. So when you're at work, but you're not really being productive. And it has much bigger knock-on effects as well. So a couple of years ago, we did some work called the Missing Million. So this is specifically looking in the UK, but I'm sure it holds true in some ways in other countries as well. And we found that, you know, of people aged 50 to 64 in the UK, about 1 million people are involuntarily workless mainly because of health and care needs or caring responsibilities. And actually getting these people back in the workforce could add about £88 billion to our economy. And it also has sort of much further impact. So if you have a mobility issue, if you're unwell, you might not be able to spend as much. So we did some work which we published last December, looking at the so-called longevity dividend, or the economic opportunities of aging. And we found that, you know, if we support people to stay healthy, to access services and products that they want and need, then actually, you know, that could be a real boon to economies. And actually, based on our predictions, by 2040, we're actually expecting older people to be spending about 63 in every pound. So if we can support that, we could really be increasing GDP as well. So there's a big case for it. You know, there's the health case, we're seeing the economic case sort of all too clearly at the moment. And throughout our project, we spoke to people across the world, be that sort of governments and international organizations. And the thing is, you know, actually what we're saying isn't very new, and lots of people agree. But the problem is we're still not really seeing that put into practice. And at the moment, across OECD countries, the rough percentage of what we spend on prevention is somewhere between 2 and 4%. And as you can see here in this graph here, is between 2009 and 2013, when obviously lots of countries were seeing sort of austerity measures put in place, that sunk even further. And obviously at the moment we're just sort of on the brink and half in the midst of another COVID-induced recession, and it's a really critical time to make sure that we're not cutting there again. And if anything, really, this has shown that's not the place to cut, because the economic consequences further down the line are so much bigger. And so in our report, which we published this February, we set out our sort of 3 key recommendations of where we think we need to be going to really start making prevention across the life course of reality. And that's to democratize access to preventative interventions and sort of remove any access barriers that there are, be they sort of physical barriers, mobility barriers, or sort of softer ones, to work hard to inspire and engage. And I think that's where we come into that sort of health communication point again that Antonio mentioned. And potentially there's some opportunities at the moment to really make the case for quite how important it is. And then we need to learn how to really effectively utilize technology. And I know Mike will be touching on that a little bit later as well, so I won't go into any more depth there. But obviously these are the sort of the big picture recommendations where we want to be going. I think in the short term, there's a few other considerations. So the OECD has just launched a report saying that the UK economy is likely to suffer the worst COVID-19 damage, but actually across the world, we're likely to see really heavily induced recessions. So again, around the point, we're probably going to see cuts, and it's really important that they don't go into health at the moment. If anything, actually, we need to be doubling up. I know Antonio mentioned earlier sort of the backlog around care. There's a huge backlog as well around health and healthcare appointments, and much more sort of regular routine checkups aren't really happening at the moment. And in some ways, to be fair, why would you think, there's a lot going on in people's minds at the moment. Why, a flu immunization or something might not be the first thing on your mind at the moment. So I think there's a really big job from healthcare systems to double up efforts and actual capacity to be able to deliver those, but also be really proactive, and especially people who might still be asked to shield for longer, who might also be at higher risk. How do you get to them? How do you make sure that they feel safe to go in to a GP surgery or pharmacy or wherever they might be receiving preventative interventions? As shown here by this wonderful image, of course, we have the flu season coming up soon here as well. So I think we'll have to have a real sort of concerted effort, because I think having a flu epidemic on top of this would probably just add to the burden. And the final point really around all these people at the moment needing to shield. How do you get to them with these preventative interventions to make sure that the crisis we're experiencing at the moment doesn't feed into a much bigger crisis further on? I think in the UK at the moment, with the backlog of sort of routine appointments that have had to be rescheduled, people are expecting at the moment that there might be a 10 million long waiting list in the UK by Christmas for appointments. So I think it's a real time now to double up on resources and get out there. So that's everything from me. I've just put my contact details up here. We are, with everything that's going on, we are planning the second phase of our program on prevention in an aging world, to move from the sort of, the why case that I mentioned at the beginning to how we can deliver it. We'll be obviously learning a lot, I think, from the current pandemic, but also honing in a bit more on those recommendations and what they mean. So do feel free to send me a message or something if you'd like to get involved. Thank you.
Thanks, Lily. And both Lily and Antonio emphasised, of course, how COVID has hit heavily on the older population across the world, and certainly very, very true. Also, the importance of policy responding to the challenges that we are facing, and the importance of preventative healthcare as part of that. And actually a theme starting to emerge from the two speakers, but also from a couple of questions around ageism and the extent to which ageism has driven policy in this space. So maybe we'll come back to that later. I think we're going to move now from Portsmouth over to, I think it's Omaha, isn't it, Gisela? And I won't give you very much of an introduction, except to say Gisela is the Global Advocacy Officer for Home Instead Senior Care. So Gisela, let me pass over to you.
Thank you, David. Good morning and good afternoon, everyone. We're delighted to be here and part of this conversation on behalf of Home Instead. Coming from Omaha, Nebraska, the middle of the country, I'd like to take a moment before I dive into trends that we're seeing through being on the field to share a bit about our organization for those who may not know about Home Instead. We are the largest home care provider around the world. We've been at this for 26 years, providing care in the home for older adults, however they define home. So we're out in places where people have lived for 50 years, assisted living facilities, independent living, hospitals, nursing homes, and so forth. Our services allow people to age in place with dignity and respect and choice. And we also empower our family caregivers, giving them peace of mind and respite as we support their loved ones. We have 1,200 locations around the globe. We are a global organization, a franchise model, and at any moment we have more than 100,000 caregivers, professional caregivers who are trained to provide care out in the field. Our services range from companionship, activities of daily living, medication reminders, all the way to 24/7, very hands-on, skilled care. And more than half of those we serve have Alzheimer's or other dementia. We have provided care in Wuhan, China. So when we talk about being canaries in a coal mine, we certainly are across the world. We've seen this firsthand. And so we were delighted to be asked to be part of this conversation today because from our in the field, on the ground experience, we have a perspective about where we think healthcare needs to go and where we should all be thinking. And it really supports what my colleagues Antonio and Lily and what Mike will share in terms of what all of these different experts have been saying about aging, and that has been accelerated through this pandemic. I just have a few minutes. I could talk to you for hours about this topic, but I just want to, for the sake of time, high level address a few themes that we've seen. And hopefully we'll be able to dig into these deeper through the questions you're asking in our conversation as a panel. So the first trend that we're seeing and that we're very passionate about is the need to expand our healthcare ecosystem. And through the COVID pandemic, we have seen a lot of attention around how we define essential healthcare through regulation, facility lockdowns, and so forth. And this has really occurred around the world. And what we've been excited to see is that we're opening up how we define essential healthcare to bring in non-traditional providers. So home care, our services have been defined as essential healthcare. And we've also seen technology providers and others being included in that conversation and those services. And we believe and have for some time that if we want to truly transform healthcare globally to support our older populations and frankly, everyone, it's going to take all of us working together, bringing in our traditional and non-traditional healthcare players to provide that best care during pandemics and otherwise. Along those lines, a second trend we've seen is that everything that can be provided in the home in terms of healthcare should be, and we believe is going to be into the future with the advent of technology and so forth. We know that that's been happening more and more in the healthcare world through technology and people having more access to their data and apps and all of those things. We know during COVID that home has been defined as the safest place to be, and many of us have had to shelter in place at home. So again, to transform our healthcare delivery system to meet the needs that Lily articulated in terms of how many people need support, we believe we need to provide more in-home care, healthcare in the home. And we think organizations like our services, home care, as well as technology providers can support that we can help deliver and advance healthcare and scale it in a way it hasn't been done before. And again, it's going to take all of us working together. We've seen that through the pandemic. As Lily noted, we've been unprepared, and part of it is we're not effectively integrated. It's a healthcare conversation, guys, so we have to talk about data, right? We need data access. We need better data flows so we can provide better care and provide care in place. We need to engage all of our key stakeholders in this journey as we provide more care in the home, and that includes traditional healthcare providers, technology, pharmacies, payer sources, non-traditional providers, and certainly the family and the patients, the seniors receiving that care. Another trend we've seen being canaries in the coal mine, and frankly, this is not something new for Home Instead, is the need to end social isolation for everyone, but especially our aging population. And through this global pandemic, I think many of us being in quarantine, we've experienced social isolation in a way that we maybe never have. We haven't been able to freely come and go or to connect with those we love, to experience events that bring us joy, visit places we want to go to. We all recognize it's been incredibly challenging for us as humans to be cut off from people and things that we care about. And for most of us, when the quarantine requirements begin to be lifted, which we're starting to see, we'll be able to go back to those social connections. We'll be able to go to those places that we care about and connect with people that we love. What we've experienced in the short term through COVID, though, is sadly what many of our elderly population experience every day. and they don't have a lift at the end. They don't have an end in sight. It's their last chapter, and they're experiencing that social isolation that we've seen going forward on a regular basis. And in our time at providing care at home instead, we see the impact of social isolation on older adults. And many of us that are in healthcare understand the impact on mental and physical and emotional health, how that social isolation can have those negative impacts and results. And we also know the power of social engagement and relationship and connection to help seniors thrive and combat isolation, and in some places actually slow the decline of Alzheimer's and other dementia. And we are hopeful that because more of us have now experienced socialization, we can empathize better with our elderly population, what they're experiencing on a regular basis. And perhaps we'll now have a greater urgency to combat social isolation for seniors. We think there's a number of ways to do that, and we've been experimenting with those through the pandemic. We've all had to step up and try to find ways to connect. And we think we can take those solutions that we've created in the short term and scale those and breathe life into them long term, so that they're become part of a way of life, and especially with empowering our senior population. One solution that we would suggest, and Mike, my colleague, will be speaking about it, but it's really about the effective way to integrate technology and touch, high tech and high touch. If we can bring those solutions together in an elegant way, we believe that's a way to address things like global pandemics, but really to eradicate social isolation. So that's really our fourth trend we've seen from the coal mine, is the importance of integrating those high tech and high touch solutions. And we think that for us to transform healthcare, we need to look at the value that technology brings in terms of scalability and data opportunities and a way to elegantly scale things, right, with the human engagement piece of the puzzle, the high touch support, which we get through organizations like Home Instead with home care and other in-home services, and certainly empowering family. And we think that to most effectively deliver healthcare, we're going to need to come together to invest in these solutions and bring in the engagement, the high touch piece, to ensure that our senior populations are able to access the technology and use it in the best way to empower all of us to enhance their care. And again, Mike will be talking more about that. A fifth trend or theme we've seen is the need to attract workforce to our essential healthcare professions. So for years, I think we've been discussing around the world the need to bring more workforce to healthcare, more nurses and CNAs, nurse practitioners, and so forth. We have that same need in home care. Our ability to scale these essential healthcare services and deliver more care in the home and do the things we think we need to do to transform healthcare, it rises and falls on workforce, and we need to bring more people to these important industries. And we think COVID has really shown a light on the need to empower more workforce, because we're going to have a demand that we don't have capacity to respond to. We've seen increased rates of unemployment in the COVID situation as well. I believe both Antonio and Lily addressed this in terms of we have industries that have had to shutter up in terms of retail and restaurant and hospitality and so forth, where people are out of work and are desperate for that. Is there a way to leverage this incredible opportunity for the need in essential healthcare to add workforce? Could we take our unemployed workforce, people that are looking for work, and help them, empower them, train them, reskill them to transition to healthcare, so that we're able to meet this increasing need in our healthcare space, not only in response to COVID and the flu and so forth, but just our aging population in general. And we would suggest that's something we should focus on. Lastly, last trend we wanted to highlight today as we get into our conversation is just the ongoing and increasing need to support family caregivers everywhere. We're all familiar with the exponential growth of our aging population that we're facing now, will continue into the decades. And we know in order to support our older population effectively, we have to empower and support family caregivers. And through the COVID, as we work with family caregivers everywhere around the world, we're seeing increased responsibility on them in terms of not only caring for their aging loved one. Many people moved their aging loved ones from facilities to their homes, but also increased responsibilities in other places as parenting, homeschooling, working, and then trying to maintain our health. The panel suggested I share this story. I personally have experienced this. I'm a mom. I have a 9-year-old daughter. She's amazing. I became, through the COVID, her 4th grade teacher, which was Howie Terrible, God bless her. But I also worked full-time at home instead. My mother has been quarantined. She's in her 70s. I've been her lifeline and support, providing her groceries and food, making sure she's safe. And my stepfather has been quarantined in a facility. He has dementia. And so I've been helping them navigate that, on top of just personally navigating being quarantined. And I think what all of us have experienced through this COVID situation. And to be clear, I'm not special or unique. My story is, I think, what many of you are probably hearing and listening on the phone you can relate to, and you're probably nodding because you understand what it is to be a family caregiver and what COVID has done in terms of increasing our responsibilities to our loved ones, which we all gladly take on. But there's a reality that for us to continue to navigate things like global pandemics and the age wave of our world, we have to continue to empower and support our family caregivers through the healthcare system and otherwise, through workforce and government programs and so on. So those are just a few themes. There's many others, but we'll hopefully get into those with the Q&A. And again, we're delighted to be part of the conversation. We're grateful to have been canaries in the coal mine and to be able to share our learnings to help us all grow and transform and become better and stronger. So thank you.
Great, thank you very much. And I think the combination of the extraordinary opportunities that come from technology and data on the one hand, but actually the real opportunity that also comes, but from people, you know, actually the real shortage of carers across the world, the importance of informal carers in this space. I think it's you know, a slightly different angle, and I think both of those came together extraordinarily important. I'm going to pass on now to another friend of ILC's, Mike Hodin, the CEO of the Global Coalition on Aging, who I think is going to talk a bit more about the work that that they've been doing around technology in this space. Mike.
Well, thank you very much, David. And it's a pleasure for the Global Coalition on Aging to be joining you. And thank you, Gisela and Lily and Antonio. We're delighted to be part of you. Before I jump into what I was asked to talk about, and mainly around the innovation point, I noticed in the chat function there's a note from Rain Strobel. I may be mispronouncing your name, from talking about Northwest University in South Africa, having done research on training unemployed people to become caregivers. Wonderful, and it's, Gisela, as we know, one of the great virtues of these virtual settings where we can have these global conversations, and this training that's taking place in South Africa. I'm looking forward to learning about it and how we can apply it. So thank you for that comment. Let me open up my few minutes just by reminding us that 2020 is the launch of our Decade of Healthy Aging. The WHO major program, which of course is now part of the UN. It's explicitly within the Sustainable Development Goals #3, but probably links to several others as well. We'll get the formal and official launch on October 1st of this year that aligns with the Day of Older Persons, the UN Day of Older Persons. What an inauspicious beginning to the Decade of Healthy Aging with COVID-19, where, as we've all said, not only the global pandemic of our millennia, but one that affects in large measure, probably out of proportion, older citizens around the planet. But it is important to recall that the reason we have this Decade of Healthy Aging is because we will have, in the next couple of decades, 2 billion of us on the planet over 60. And even more interestingly, more old than young, which already is the case in developed countries, and very, very shortly will be the case globally. We know that in many societies, from Japan, many Europeans, Korea, and others, South Korea, we already have over 30% of the population over 60, and that's going to move very rapidly. So we're in a place here where healthy and active aging is essential not only for quote unquote older people, but for our entire societies. And not only from a healthcare point of view, but from an economic point of view. If we don't get this right, economic sustainability and economic growth itself is in question. So let's not forget that this is not just about older people, it is about our entire societies and also, and not least, our economies. With that, let me highlight 3 points about what we see out of COVID-19, if there is any, the silver lining in it, which we've talked about as innovation. But wrap it up in one sort of notion that also may be somewhat controversial, but we think very, very true and important to recall, namely, in many ways, therefore, thinking about innovation and COVID-19, we've been preparing for this for years and even decades. Innovation does not come out of the blue. And therefore, in 3 particular areas that I'd like to highlight very superficially and very quickly, and then maybe talk about in the Q&A, it's because companies, private-public partnerships, all of us as individuals have been a part of this innovation drive, this innovation cycle that with COVID-19 we can build upon. So the first area is what Gisela and Home Instead already referred to, namely caregiving. And David and our friends in the UK, we recall that a few years ago, the Queen's Award on Innovation was given to Home Instead. That award is normally thought of for high-tech startups, but those who awarded that understood that caregiving and elder caregiving in particular is as important an innovation as any startup high-tech element, and therefore recognize that. So too with COVID-19, and it is precisely, as Gisela alluded, that we understand that this elder caregiving is even more essential out of the COVID-19 needs and learning. And it's essential in a way that leads to thinking of caregiving in general and elder caregiving in particular as a part of our health ecosystem. We know that in many countries around the world, on the one hand, there's healthcare, on the other hand, there's the social care. We can no longer afford this. Elder caregiving is an essential part of our health systems and clearly a part of the health ecosystem, which we know from a pandemic is utterly essential. The second area that I'd like to allude to is innovation in, let's call it pharma, pharmaceuticals, medicines, therapeutics, and vaccines. And in that context, I'd like to spend just a moment and tell all of you about the report that the Global Coalition on Aging with the American Federation on Aging Research has launched today on vaccines, on the importance of vaccine innovation. We held a seminar on it back in the fall of 2019, feels like decades ago. Among those who were very central to it was my partner in it, Pfizer, who also is a member of the board, Paul Vanderbroek at Pfizer. And thank you, Paul, if you're listening. But we're now launching this, the Global Coalition on Aging and the AFAR report. And it is to highlight that it's not only in medicine development, think Gilead's Remdesivir, a therapeutic which is transforming the ability to care in this time of COVID-19, but vaccines themselves and others that we will see. And we are seeing just in today's papers, many of us have seen the headlines where we expect several vaccines to be in human trials very, very rapidly. This does not take place in normal times. It takes place as a result of the collaboration, the special kind of thinking, the efforts, the relaxation and regulation that we have because of this pandemic. So our innovation in therapeutics, in vaccines, however, cannot take place without the core underpinning that we've had for years and decades on which to build. The third area is telehealth and telemedicine, which I think we all now know about. It is transforming how we care. It is transforming healthcare itself. We were talking to some experts in Japan the other day, where within about a month, the Japanese government completely changed the regulation and the payment structure to provide further incentives for telehealth and telemedicine. And it is being picked up in a way that one would never have imagined even a few months ago. This is a good thing. In large measure, telehealth and telemedicine is still the relationship between traditional and conventional healthcare with hospitals and doctors for our needs when we're at home. We're looking for the moment when this innovation will truly scale and get to an even greater element where we can use it as part of our prevention strategies, being at home and not just waiting for the acute care setting, which was typically the way it had been. So let me conclude by just saying again that we have these three areas of innovation: elder caregiving, therapeutics and vaccines, telehealth and telemedicine, which are finding value and extension in a matter of weeks and months that would normally take us years and sometimes decades. Our big question is to understand why, understand the relationship between public and private sector, the value of innovation, and what we could take out of COVID-19 as best practices to become part of our normal way of living, normal public policy extension with respect to the value of innovation. That's applicable in those three areas. There may be others that we're going to learn about and find, but let's not let this just be in a pandemic, but let's bring out of it these best practices. And David and Lily, as you have said for ILC UK, applied not only for treatment, but for prevention as well. We're all about, we've talked about wellness and prevention for decades. Maybe COVID-19 will help us move even more rapidly to that place as we build on these innovation pieces. Thank you very much.
Great, thanks, Mike. That's really useful. And I think some really common themes across all of our speakers there. We're going to move into some Q&A, some discussion now. So please do add your questions into the Q&A box or onto Twitter using the hashtag Canary in the Coal Mine. I'm going to perhaps start off. We've got another friend of ours is on the line, Ken Bluestone of Age International, who's talked about, who's asked, given the what sort of practical advice do the speakers have for health ministers in low-income countries who may already be under significant pressure to deliver healthcare and may find this even more difficult in the future? So, to what extent, how can we ensure that low-income countries are learning some of the lessons that we've been talking about, and indeed benefiting around, the potential of new technology, for example? I wonder, Antonio, if you wanted to sort of kick off on that one.
Oh, I'm sorry. My phone is working better than my computer. So, well, in terms of advice, and I'm working closely with the government of Colombia, and the issue of COVID-19 and aging. I think, as I was saying in my presentation, that the first phase was reaction, epidemiology, geographic, reduce speed. The second time it's
controlling the speed, what epidemiologists call they are, and make sure to go ahead, target. It's a key issue here. So the first recommendation that I said is, if you're gonna be target the vulnerable groups, identify them regardless of the geographic area where they are. You can use geographic criteria, but then you need to prioritize and go ahead. So now, when we are thinking about public health and target to the senior citizen, we have to be, I believe, more creative. Tracing, test, and isolate. Testing, it's fundamental. Trust, knowing that it's going to be there, that I'm going to be safe, it's very important. And I was raising the issue of marketing. We have to do a better job in terms of marketing in the sense of the message. How can we make the family message more inclusive so that the benefit go in both ways? It's something that I'm puzzled about it, and I think we need to be working more. So in short, I will advise to monitor cases there, but also by age, and monitor actions that target the elderly. 70% of the deaths are happening in that age group. It's different than the pandemic that we have in 1980, which was the younger. This one is the elderly. So if you do better job in targeting and helping, then you're gonna save money that will help you down the road. So I'm making the effort to design policy that help the elderly population more directly. Thank you. Over.
Great, thanks, Antonio. I think Lily talked about our prevention project, and one thing that's worth reflecting on that is we focused very much on G20 and the wealthier countries. One of the reasons we did that was because there is so much more data, and I know this is an issue that Ken has raised a lot, that actually the paucity of data in low-income countries, and it's an extraordinarily important part of, I think, the solution is making sure we understand what's going on. But equally, I would say that the messages that Lily emphasized, democratizing access, engaging healthcare professionals, the use of technology are as relevant in low-income countries as they are anywhere else. Technology doesn't have to be high-tech, it can be low-tech as well, and it can be, innovation doesn't have to be high-tech, big data. Anyone else want to come in on sort of low-income countries?
Yeah, I can. Oh, go ahead, Gisela.
Okay, thank you. I would just suggest, I think where Antonio went in terms of marketing, we think about education. Education is the great equalizer. And as I mentioned earlier, the importance of family caregivers, the family unit, in helping our elder populations navigate this pandemic and other health issues. If there's a way for us as governments to better connect with families and community, we can provide a lot of that support locally. If people are educated and understand and are supported in how they support the older population. There's that quote, it takes a village to raise a family, to raise children. And I think that's also true from what we've seen in terms of how we empower and support our older population. So if we can empower community throughout everywhere, but as we think about our developing countries, there are low cost and very effective ways to educate and train and support so that they become almost like frontline workforce to support the effort. So thank you.
Great.
Yeah.
Mike.
Yeah, thank you. So great question, Ken, as usual, and nice to hear you. And thank you for all the great work you're doing in many areas, but including in the area of dementia and Alzheimer's and other dementias, which is a way to talk about this. As David said, currently the numbers with respect to aging populations tend to be in the developed world. Super aging Japan, South Korea, the Europeans, you in Europe, et cetera. But as we draw our lines out just in a decade or so, we will find that middle income and poorer countries are aging as well, even more rapidly. As Ken, you know quite well, we will have more people living with dementia and Alzheimer's in African and Middle East countries than in all of Europe, and more living with that terrible disease in Latin America than in all of North America. So the data is getting us there. But I would make another point that I think was inside your question, which you framed in terms of health policy. And one of the key learnings, and again, Japan or Germany, the UK, are teaching us this as they are at the other end of the aging societies, or Finland even, is that if we continue to think of aging as a health issue, we're missing the boat. Health ministers are important. Health is critical, but this is about economics, it's about society, and it's about sustainability. And one of the great lessons from Japan in particular, as they led the G20 last year, was to bring in at least 4 or 5 of their ministries, finance, economy, industry, along with health, to address the aging and wellness challenges. So as we begin to look at that in the poor and middle income countries, that's the other piece. They should be thinking of it as part of their economic plan, not just part of their health plan.
Great, thank you, Mike. Let me perhaps move on to a question that I sort of hinted I would come to earlier on around ageism, which a few people have talked. We've got a few questions around ageism and indeed the role of human rights. How much do the panel think that the response to COVID has highlighted age discrimination within healthcare systems? And I suppose, importantly going forward, what should happen next? What do we need to do to ensure that, that healthcare systems are not being ageist in the way that they deliver services and that we are respecting the rights of all adults, particularly and older adults? Does anyone want to come in on that?
I'd be happy to start off on that. And I saw another question as well in the Q&A, which is sort of framed around, well, how can you convince people to invest in older people when lots of people think they're going to die soon? I think that's how it was phrased on the Q&A. And I think it sort of ties in around Mike's point of really, it's not just a health issue, it's sort of bringing in all areas together. And some of the work we're doing at ILC, I think, is about trying to reframe that a little bit and think about the opportunity in that, just because you're older doesn't mean you don't still contribute, and that there's no worth in keeping people active. And many people might still be working or working part-time, might be spending, might be caregivers or looking after grandchildren or something. So I think it's a lot about sort of reframing that messaging and making sure that we see older people just as much contributing as anyone else in society.
Thanks, Lily.
Yeah, I would. It's very well said, Lily, and I would. We at the Global Coalition on Aging would fully echo that. COVID-19, realistically, but unfortunately, has highlighted, let's say, the weaker parts of our older citizens across society. And because of the relative risk factors and vulnerability, that's been understandable and necessary. But that's why I opened up my point to remind us that we are launching the Decade of Healthy Aging, which is not just about better healthcare, absolutely necessary, and different kinds of healthcare, but also about enabling work and activity, whether you're 22 or 82, in the way that you want. And as many have said, and to pick up on a point that Gisela mentioned, ageism seems to be the last acceptable form of discrimination. So, we should highlight that. Nevertheless, there's no question that within our, even before COVID-19, within our health system, in many ways, and perhaps very ironically, it's one of the worst kind of elements or forms of ageism. A good example that we've seen is in the area of heart failure, where, as many of you will know, and certainly the experts much better than I do, but some of the early symptoms of heart failure are conditions like being weaker, feeling tired, maybe being a little dizzy. And when someone who would have been or will become a heart failure patient thinks about it herself, or he goes to his doctor, oftentimes, well, you're 82 and that's what happens when you become 82. No, she has heart failure. Vision loss, age-related macular degeneration, which was alluded to earlier. Well, when you get to be 78, that's what happens. You begin to have vision loss. No, you have age-related macular degeneration, about which something can be done. And as Antonio said, we're at a particular inflection point right now because many of those who require the earlier detection that would lead to diagnosis and then treatment have been staying at home, being taken care of by home and said caregivers oftentimes, but they're nevertheless at home and afraid to go to the doctor. So I think when we come out of or begin to come out of COVID-19, that's going to be even more important to highlight these discriminatory elements that are built into our health system.
David, if I could jump in as well, I think well said by Lily and Mike. There was a comment in the chat box from Francis Zinodin. I probably mispronounced your last name, but I really appreciated it. And I think it summarizes, she says, or he says, perhaps we need to convince governments to discuss and prepare for longevity as opposed to aging. And I think that so much of it's mindset. We're all aging. It is a universal human experience. It's one of the very few universal human experiences. And so if we could get people to understand that this is a journey, it's just not this last chapter, but we're preparing for aging and longevity all along the arc of our lives. We suspect that would help address some of this ageism that's embedded within systems like healthcare and so forth. I appreciate where Mike went. It's not just about healthcare, it's about all of these different institutions of humanity that connect with people. I think, as I mentioned earlier, that the pandemic has actually, I would propose, helped us better understand the aging experience, social isolation, what many of our older populations everywhere are experiencing. We've had a taste of that, and perhaps that will inspire us to be more intentional in how we connect and think about our older populations. So we would be supportive of that and hope that's where the future is and how we transform all of our thinking, because we're all going to experience it if we're lucky enough, right, to live long enough. And then lastly, I think one thing we saw that was troubling was shelter in place directives or quarantine directives that just had an age. Like everybody over this age is sheltering in place. And we understand that none of us, as Lily said, were really prepared for a global pandemic. So everyone is well intended in trying to protect and support. And so that's where these regulations and policies get enacted. But that's, to Mike's point, saying that someone at a certain age is all of a sudden at risk, vulnerable, what have you. And we have vulnerability in health through all ages. And so we would suggest in the future that we're more thoughtful about how we present where our older populations are able to go and interact and so forth in pandemics, because to create sweeping requirements around age continues to just lean into that ageism concept. So thank you.
I think what I will add a couple of comments from what I have said by the panelists. One issue that I'm if economists and sociologists tend to see discrimination in different ways. Economists is more individual, and we have what is called statistical discrimination or taste discrimination, and sociologists tend to look more at institution and culture. But in simple terms, if you empower, you reduce discrimination against certain groups. So definitely you observe during this COVID-19 this discrimination against the elderly. One issue that we haven't talked much about it is we don't know yet what is the impact of the disease on the wealth of the elderly. And we need to have more information about that, because if the younger stay without work, and it could happen in developed society, and the elderly were transferring part of their asset, how they're going to be after this is important, because we may need to have better policies to protect and compensate, not only in terms of health, but also financially. So issue number one. So issue number two, I think that we need to make more pressure about policies that empower financially the elderly. So I said it in my intervention, the fiscal stimulus need to include not only policies that are traditional policies to increase the demand, but policies that protect and compensate the senior citizen. I don't see that in a lot of the conversation. And then the last issue I want to say, can you imagine any other industry that have a failure like the long-term care and the nursing home that we observe in the United States and in other societies, where 40% of the death happen because of you have a lot of regulation, but implementing those regulations is very difficult. So, you need to rethink about the incentives, the institution, the culture behind what we saw was going to be the way to provide care as the society was less able to provide care at home. As I said, more women working, less people to take care of the elderly. We were thinking that as we get really fast older, we were going to count with institutional caring. So the question is, how can we make them better? Some of them are for profit, some of them are not for profit, but definitely just regulation, it's not enough. A lot of the institutions were not prepared before the pandemic, so it's not an issue just related to the pandemic. So, and then the last issue is we need to think about technologies that help. But when we think about technology, we need to think about what type of technology are adopted by the group that we wanted to benefit. We tend to think about, we're gonna trace with cell phone. Well, if most of the people, 70% of the people that are dying are not using devices or are not, you need to think about other ways. So we need to start thinking creatively to help, and then you will reduce this type of discrimination. Your policies will be better targeted. Thank you.
Great, thank you very much. I think just to pick up on a couple of those points, I think the wealth point is really interesting. Give you a slightly different angle if you tie in the wealth and Gisla's point about shielding. We're about to publish a piece of work in a few weeks' time that points out that older people in the UK already spend over 50 pence in the pound as consumers. It will soon be 63 pence in the pound. If everyone over 70 is forced to shield, they're not going to be able to spend. So the knock-on impact on the economy, if we fail to ensure that older people can engage with the economy, could be extraordinarily important. I think the other thing to pick up on Mike's point is add another couple of examples. We did some work, I did some work about over 10 years ago now on pain in old age. And it was very clear talking to older people that older people were often told you should expect a few aches and pains at your age. And the impact of that was that older people then didn't get access to the same treatments as younger people. It'd be interesting to see if that is true. Slightly different example that I've heard from Ashton Applewhite, the brilliant Ashton Applewhite, who will be joining us at a webinar in July, who talks about a doctor coming and saying to her that she's got a bad hip and it's because of her age, and she says, but the other hip's the same age and that's fine. So I think extraordinarily important, the ageism point. I think
David,
can
I jump in on that? First of all, to Ashton is fabulous, and if you're listening, Ashton, thank you for everything you're doing. I also recommend everyone take a look at Ashton's TED Talk, Ashton Applewhite, which is a little bit old now, but still worth every moment of watching. Osteoporosis, which of course is what will lead oftentimes to problems with hips and other elements like that. Again, we know who, in the developed world, we know who 80% of those with the first fracture are. And yet we don't do enough in treatment, in rehabilitation, in order to avoid the second fracture. The second fracture is what then leads to really bad stuff, including frailty, social isolation, mental depression, and other pieces that are not only huge burdens on quality of life, but that's where the real health costs come in. And why we don't do the right kind of treatment for the 80% of people who we know who they are, again, may lead to this ageist kind of element. Well, you're 82 and, you know, that's what happens. No, there are things that could be done and could help you, help your family, keep you active and engaged, be good for the economy, and you know, very valuable on all sides of quality of health and economic burden. So thank you for that reference, David.
Thanks, Mike. Let me move on to a question we've had from Lois Pivot-Dum. You won't be aware, but we probably wouldn't be here today on this webinar if it wasn't for Lois. So huge thank you. We were due to be having a meeting together in person in Geneva alongside the World Health Assembly, but as you will understand, that got cancelled. But I do hope that Johns Hopkins ILC and the Global Coalition can find another opportunity to go to the WHO to present some of the work and try and encourage change and highlight some of the lessons that we've learned from COVID. So Lois has said significant spending is already targeted at older people, but focused on hospitalization and treatment of chronic care. Picking on Lily's point, how can we better shift to preventative care? We've got tools for screening for chronic disease, vaccines such as influenza and pneumococcal disease, all that could help improve the downstream effects of disease or outcomes from COVID. And given that, is there any sort of data or arguments that we're missing that could help encourage the focus of prevention of disease? You know, as part of preparedness. So, and of course, Mike mentioned his work that they've done publishing today on adult immunization. So, you know, what else can we do in terms of getting prevention on the agenda? Who wants to come in there?
I'm happy to just one perspective on prevention, and I'm sure Lily, you probably want to dive in here. We think about prevention and what steps we need to take to empower wellness, and so much of it is about behavior change. So we think about prevention and wellness when it comes to all of us, but aging population, so much of it comes down to managing your medication appropriately, nutrition, exercise, and following up with healthcare providers. And humans, we are stubborn when it comes to behavior change. And what we would propose is if we could have more of that human touch, that human support when it comes to enabling behavior change that advances wellness and prevention, as well as ways to access metrics about people as they're going down their health journey, they're traveling their health journey. We think that we could better advance and address chronic conditions earlier on, again, to support this concept of longevity. And what we see in home instead is our home care services can provide that support. Partnering with healthcare, partnering with technology, we can look at different facets of wellness and prevention and make sure that the older adults we're supporting are taking the steps they need to take to advance their longevity and their health. We know that when we have a caregiver in the home spending time with an older adult, they walk more. They just walk more. And we all know that movement is important to advancing prevention and health. They eat better. We address social isolation, which we know impacts health. We don't think it's touch alone, home care alone is the solution, but again, it goes to our theme of bringing together these different providers with technology and human engagement to really help people take control of their health journeys, their longevity experience, and take the steps they need to address their chronic issues so that they're advancing wellness. And then they're in better position to stave off things like COVID. They're in better health. So that's just one perspective. We think there's opportunity there with the high tech, high touch approach.
Great, thanks. Lily, do you want to come in?
Can I?
Oh,
Yeah.
Antonio.
Oh.
Go on,
Oh, sorry.
Lily first,
No,
and
go
then
ahead,
Antonio.
Lily. So.
Yeah.
Yeah, no, and I think in Lois's questions, you know, mentioned a few things as well around, you know, not only is it a problem already, but at the moment, obviously in the current context, you might not have people really asking for it. So you don't have the direct sort of demand there. At the same time, I mean, especially in the short term, we're going to be really overwhelmed with some acute needs. So it's going to be even harder really to get that spending towards prevention. And then obviously the problem generally with marketing something that if it works, you don't notice it's worked. So the sort of prevention paradox. I think some really key things are sort of about getting the right people in the room. So I think, you know, when we held an event also alongside the G20 in Japan with health ministers, and you know, the fact is that most of the time they might agree as well. So it's about, you know, looking at who makes the decisions. It's getting the right, you know, argument in front of those people. I think it's about changing the argument a bit, and really, you know, in some cases, I think a cost-benefit argument can work, and that's partly why we've done some of our work looking at the sort of economic impacts, and also sometimes something around framing. And I know, Gisela, you mentioned sort of behavior change, and we did some work on, which was specifically on flu vaccination, and sort of looking at attitudes and what works. And so we did interviews in, I think, the UK, Australia, Canada, and Japan. And one thing that we found is that, you know, people want the kind of positive messaging of not, oh, if you don't do this, you're going to be in really poor health, but actually, you know, don't you still want to be active and doing all these wonderful things when you're 80, 90? And I think we can definitely learn a lot from that, of the sort of positive messaging of what you could get rather than what you're trying to avoid, especially because, again, if you're preventing it, you don't actually see it.
David?
Right, please, yeah.
Thank you. Another way to think about this, and I may be overly optimistic, but as we said with learning from best practices about innovation, one of the things we're learning from COVID-19, and I'm actually stunned at the relative compliance, is all of our individual stewardship or responsibility of public health. So although we can all find exceptions, the amount of compliance with wearing masks, social distancing, staying at home is absolutely stunning when you think about it population wide. And we need to learn, was there anything other than, well, this is, you know, a crisis, pandemic crisis that only happens once, hopefully once every 100 years or so, or are there other pieces to that that we could learn from and apply? Another related element, which we're beginning to look at, is the relationship or the responsibility of the employer in this public health arena. The employer over the last decade or maybe 2 decades has already accepted that they have a role in the environment, in sustainability. You know, it plays out in many different ways, from green architecture when buildings are being built and engineering, to, you know, recycling as a matter of course in every part of office space. From COVID-19, the employer now knows that they not only have a social and almost ethical obligation, but a direct obligation to get back to work. So there are a lot of elements here that we can apply that we could learn from, that might be applied to prevention strategies of the way people are behaving differently from this pandemic.
Great. Thank you, Mike. I think the employer point is extraordinarily well made, and I think employers, yeah, and one question I think I have when I next talk to the WHO is going to be about how can we ensure that employers are part of the conversations around the decade of healthy aging? How do we make sure that companies are engaged, because they have an extraordinarily important role to play? I'm very conscious.
Yeah, well, I can't help but jump in a provocative way. One way is for them not to automatically assume that if you are an employer or in business, you're somehow bad. So if the WHO can change its culture on that and bring it in a full way, the way it happened as we were creating the decade of healthy aging, that would be a huge step forward.
Great, really good message. I'm going to run to one last question and then give all of our panelists 30 seconds or so for any final comments. And I'm going to jump to a question from Paul Dinsdale, where he asks, do we think the current pandemic will encourage more younger people to go into caring professions? And is government prepared to put more funding into social care training? From ILC UK's perspective, we've done some really interesting work with Anke Hanover on the need to get more men into the care sector, for example, but also the challenges around, in a UK perspective, around migration and how we ensure that migration limits don't prevent us from having the sort of skilled care workers we need. Yeah, so I think very relevant to the point that Gisela was making earlier. I think there is clearly a challenge, though, that one of our partners mentioned on a previous webinar, that of course there is a risk that the care sector will be increasingly competing with the health sector for staff over the next few years, with health itself, demand for health increasing, and that actually making care even more of a challenge to recruit for. Gisela, what's your take on this? How do we get the skilled workers across the world?
Absolutely. As I said earlier, it's going to take all of us working together, and we need to attract more workforce to healthcare and home care, and developing technology that empowers our older populations. We're very passionate about this at Home Instead as well, because we see the opportunity and how the younger generations care so much and want to give back and be involved. So we actually launched a program in the United States that we will be taking globally in our other markets. We partnered with an organization called Service Year Alliance that many may know through their work on Peace Corps, Teach for America, and so forth. And we thought we should do something similar in the aging space. So we launched our Champions of Aging program 2 years ago, where just like the Peace Corps, Teach for America, we're connecting with different educational institutions and speaking with young people about the opportunity to serve a year learning about aging and longevity and our older populations and the demographics that are coming and will continue into the future, especially as we launch this decade of healthy aging. And the program, we just finished our first year. It was wonderful. We're continuing and expanding our reach. And again, we hope we light a fire and it ignites and goes everywhere, just like we've seen with things like Peace Corps and so forth. But it's really geared to a year of understanding the aging journey and longevity. And it's really lovely because it empowers our young people to understand the opportunities in the field in healthcare, technology, and other sectors to support and create innovation to empower us all in aging. But also it helps our young people to think about their own aging journey. And we would propose we should all be thinking about aging the minute we're born. There's this professor we work with in gerontology, and she says the minute we're born, we should have a pediatrician assigned to us and a geriatrician, because we're aging every minute. And we should be working together to create our own longevity journeys that meet our choices and desires as humans. And so we're hopeful with Champions of Aging and other programs that we will be able to lean into our younger generations and their desire to help and support, and ultimately bring more of them to healthcare and home care and other aging careers.
Thank you. Does anyone else want to come in on care workers, or indeed healthcare workers, and how we staff in the future?
I would like to add a couple of issues regarding that issue. I think getting into healthcare have two important indicators. One, the demand is growing and growing fast, and the trend will not change. So that's a good perspective. It's a value. It's a job with a lot of non-monetary value, so a lot of rewarding for the person who will get there. But the last issue, it's a word that automatization will not compete with you. So the trends are allocated investment in human capital and training to do better job in the healthcare industry, in home care, or other type of care for the senior citizen. I think it's an industry with promising growth. Like we said before, technology in this sector, telemedicine. I wanted to mention before personalized medicine. We need to think about preventive care and how can we use technology to personalize care for the senior citizen so that we can get better results. So it's a growing sector. So I always tell my students that it's a great sector to invest and to keep working. So, thank you.
So I would just remind us, picking up on Antonio and Gisela's point, I don't know, pick a number, 30 years ago or so, we began the revolution in employers supporting childcare. We're now at the inflection point for employers to even pick up their benefits around childcare, but add to that elder care. In the Global Coalition, we have two of our financial sector companies, Aegon and Bank of America, who are doing as much in this space as anyone because they recognize the importance of it as a benefit with respect to, in the case of the United States, 401ks and things like that. So the idea of elder care being as important to employers, workforce management, productivity, as we have come to understand childcare, is now clearly with us, and that would be another lever for us to help promote.
Great, thanks, Mike. I'm conscious we're at time, so I'm going to ask our speakers if they have a last sort of 20 or 30 seconds each where they'd like to say anything. And let me jump to Lily first. Sorry, Lily, for not giving you a warning.
Sorry, just took a second to unmute. I think I'm obviously going to mention prevention again. I think it's shown us just how important it is at the moment, and just that we really can't afford to fall behind on it with everything that's going on. I think for the sustainability of our health systems, our economy, but also society as a whole, it's really important that we ramp up services in the short term, that we develop more comprehensive preventative health programs. And as Gisela mentioned as well, really, that we work together. It's not just sort of one person's job, but there's lots of healthcare professionals that can come together, and hopefully actually at the moment is a sort of learning point where some of that is actually happening. And to be proactive if we want to deliver a decade of healthy aging.
Great, thanks, Lily. Antonio.
I will close that with a point that I made, and before that, I think we need to think about our fiscal stimulus package during COVID-19 and tailor to sectors that will benefit the senior citizen. And I think the idea of improving the institutional care, the home care industry, investing, expanding, now that the interest rate is low, could be something that it's a good point to end my participation today. So we are always thinking about demand side issues, labor, informal care. We haven't thought about supply care. At least in the United States and many countries where I live, the supply care for the senior citizen is also low, and maybe this is the opportunity to expand it. And that's an issue that I would like to conclude my participation. Think about supply issues as well.
Thank you. And Gisela.
Thank you.
Absolutely, just grateful to be here. I think one thing COVID has done is united us as people in ways we haven't been united for a long time around the globe. We're experiencing something the same. And I would suggest it's going to take all of us, public, private, social sectors, working together in a unified way to really support and empower our aging populations, not only through pandemics, but just in general. And we're all on this journey. So again, just I think the message of unity, and we're delighted that so many people joined us today through a Zoom call to hear more about this. And we hope that trend continues into the future. Thank you.
Okay. And Mike.
Thank you. Really appreciate it. We've been delighted from Global Coalition on Aging point of view. My section on innovation, to remind us that if we're going to be advocates for older persons, we also have to be advocates for innovation. But that doesn't happen automatically, and nor can we take it for granted. It has to be nurtured, and we need good public policy support, from intellectual property to payment flows and regulatory relaxation. It's all those policy elements that have been enabled during this crisis that have led to innovation in elder caregiving, in telehealth and telemedicine, in therapeutics and vaccines. Let's never take that for granted and see how we can carry that forward through the decade. Thank you very much. Appreciate it.
Great, thank you very much, and thank you all for joining us online. To conclude, the Mike's organization, the Global Coalition on Aging, has, as he has mentioned, published a new report today on adult vaccination with the American Federation for Aging Research. That publication we will send a link over to with a note tomorrow to you all, alongside a link to the slides and the YouTube recording. Johns Hopkins University are about to publish in the next few months a report around the a roadmap really around the importance of immunization on the putting immunization on the global agenda in the context of prevention. And then finally, from ILC's point of view, perhaps I'll talk about the Global Alliance webinar next week. Next week there is an even more challenging job in that actually we are going not from just two countries. We'll be going from Australia to Netherlands to Czech Republic to Singapore to Dominican Republic and so on. We've got 9 or 10 of the members of the ILC Global Alliance talking about what their experiences of COVID is from their perspective. So it will be a very quick run through, but having heard some of the passion that has come through from some of them around the things that have been going wrong and indeed right in some of those countries, I think it'd definitely be worth listening to. At that point, if you would like more information about that, please visit our website or at ilcuk.org.uk, or and you can join our mailing list from there. And so thank you very much for joining on this, and we hope to welcome you at a future event. Thank you.